How do we really truly empower patients, to manage their own chronic conditions effectively, not
Hmm.
just in a clinic setting, but day to day?
Right.
And at the same time, how can we possibly ease that huge burden on our healthcare systems? It's a massive challenge.
It really is.
But what if a fairly simple patient-led approach could actually make a big difference for something as serious as congestive heart failure?
Interesting.
Yeah, we're talking about a clear, kind of personalized plan that lets patients manage their own fluid levels, often by adjusting a specific drug, furosemide, using a sliding scale based on, well, simple daily checks.
Okay.
That's the really revolutionary idea we're digging into today. Now, our source for this deep dive, it's a pretty comprehensive medical article from Canadian Perico, and it's got this provocative title, Initiation of Congestive Heart Failure Action Plan in the Emergency Department.
Mm.
It lays out this innovative approach that might just be, a potential solution we've been looking for.
Right. Something practical.
Exactly. So our mission here is to unpack this concept, focusing on how a sliding scale furosemide plan can maybe prevent those crises like fluid buildup or even dangerous dehydration, and ultimately give you a fresh way to think about patient care. So maybe let's start with the basics. The sheer scope of congestive heart failure, or CHF. What exactly is it, and why is it such a big concern?
Well, CHF, it's a chronic condition where the heart basically struggles. It can't pump enough blood to meet what the body needs.
Okay.
And it's a quiet crisis,
Yeah.
really, affecting huge numbers of people. Just in Canada, we're talking over 750,000 individuals.
Wow.
And sadly, it significantly impacts both how long people live and, the quality of life day to day.
Right.
And then there's the financial side. Beyond that huge personal impact, it puts a staggering burden on our healthcare systems.
I bet.
We're talking frequent hospital stays, lots of trips to the emergency department. The numbers are pretty stark, actually.
Mm.
National data from 2013, 2014 showed about 60,000 ED visits just for decompensated CHF in Canada.
60,000.
Yeah, and that cost a direct $2.8 billion annually.
2.8 billion, that's mind-boggling. Just for CHF, just in Canada.
Hmm.
But here's what really gets me a lot of that cost, especially those ED visits. It feels like they're for preventable flare-ups, right?
That's exactly the point.
So it's not just a money drain. It really hits quality of life hard, and it just screams out for a different strategy, doesn't it? What's been the main thinking on trying to, get ahead of this?
Precisely. For years, a big focus in improving CHF care has been on optimizing medical treatment early on.
Okay.
Specifically, trying to prevent the condition from getting worse and stopping those costly exacerbations. The goal is really keeping patients stable, keeping them out of the hospital. And when it comes to managing CHF day to day, loop diuretics are really the cornerstone. Medications like furosemide, which is probably the most common one,
Right.
they work by helping the body get rid of extra salt and water.
Right.
That prevents the volume overload that's such a common problem for CHF patients.
So these diuretics, they're absolutely key for fluid management. But you mentioned a challenge. A patient's fluid status isn't fixed. It's, you said, dynamic. What does that really mean for managing these drugs?
It means things can change fast. The patient's fluid level isn't static. It can shift, throughout the day, sometimes hour by hour, based on what they eat, how active they are, even just normal daily variation.
Ah, okay.
So this means you need really careful and, importantly, timely adjustments to their diuretic dose.
Wow. Okay. So it really is like a constant balancing act, a tightrope walk.
Yeah.
What happens if, a patient or maybe even their doctor misses that window for adjustment one way or the other?
You've nailed the core issue there. If there's a delay, if the dose isn't increased when needed, fluid can build up really quickly. That leads to what we call decompensation.
Decompensation.
Yeah, essentially their heart failure gets rapidly worse, often meaning, boom, back to the ED.
Okay.
But the flip side is also risky. Too much diuretic or taking the same dose when they don't need it can lead to pretty significant dehydration.
Right.
And that can cause something called prerenal acute kidney injury.
Pre-renal acute kidney injury. Okay, break that down for us. What does that mean in practical terms for the patient?
Basically, it means the kidneys aren't getting enough blood flow to work properly.
Ah.
And that can lead to damage if it's not corrected. So it's
Mhm.
this really delicate balance we're aiming for. Enough fluid so you're not dehydrated, but not so much that you overwhelm the heart.
Okay, given that constant tightrope walk and how critical timely changes are, what if we could actually empower the patients themselves to do some of that balancing act? how would that even work?
Well, this is where the really interesting idea comes in, incorporating a patient-directed a sliding scale for furosemide right into their overall CHF action plan.
A sliding scale.
Yeah, and the benefits could be huge. First, it might reduce the risk of those bad outcomes we just talked about, the decompensation or the kidney injury, because adjustments happen faster, more proactively.
Makes sense.
It also really promotes patient-centered care, co-creating the plan with them. And crucially, it encourages patients to be actively engaged in managing their own health.
But how can patients realistically monitor something like fluid status? It sounds complicated. Are there simple things they can track?
That's the elegant part, actually.
Yeah.
Simple things like watching for CHF symptoms,
Mm.
more shortness of breath, maybe swelling in the legs or ankles, and just checking their daily body weight. These can be surprisingly good markers for volume overload.
Daily weight.
Yeah.
Okay.
And there's actually a key number to watch, backed by research. An average weight gain of more than zero 0.9 kilograms. That's just under 2 pounds.
Uh-huh.
That's consistently linked to a higher risk of being hospitalized for CHF. And here's the kicker. This weight gain often happens at least a week before they end up in the hospital.
A week. Wow, that's a real window of opportunity then.
Exactly, a crucial window for intervention.
So, okay, by tracking their weight daily, learning to spot those worsening signs, patients get empowered to actually adjust their own diuretic dose proactively. How does that mechanism work to prevent both problems, the fluid buildup and the dehydration that might happen with just a fixed dose?
It's all about that real-time response.
Yeah.
Like we said, a patient's fluid status changes, so why should their diuretic dose be stuck?
Right.
By letting them adjust based on their current weight and symptoms, they can bump up the dose when fluid starts to creep up.
Okay.
And, just as importantly, they can reduce the dose when they're back at their target dry weight, which stops them getting dehydrated from a dose that's suddenly too high for where their body's at right then.
I see.
It's really about matching the medication to the body's immediate needs.
That sounds, well, incredibly sensible, actually. And it's not like this idea is totally brand new in medicine, is it? We've seen similar self-management ideas work really well for other long-term conditions. I'm immediately thinking of like asthma action plans.
Absolutely, that's a perfect parallel. The asthma action plan is a well-established tool. It's usually a written template that guides patients on how to manage their asthma flare-ups themselves.
Yeah.
It gives clear instructions. If this happens, adjust your inhaler like this. If that happens, do this. And crucially, here's when you need to call the doctor or go to the ED.
Mm-hmm.
And the evidence for them is really strong. There was a big Cochrane review, Gibson and colleagues back in 2002. They looked at 36 randomized trials.
Okay.
And they found that self-management education, which includes having that written plan, self-monitoring, and regular check-ins with their doctor, it's significantly cut down ED visits, unscheduled doctor visits, hospital stays for asthma, and just generally improve patients' health outcomes dramatically.
Yeah, that's fascinating, isn't it? How the proven success in one area, like asthma self-management, really does pave the way. It shows it can work. So what does the evidence look like specifically for self-management in CHF? Is it as promising?
It is quite compelling, yes. There are good studies there, too. For example, one randomized trial by DeWalt and colleagues in 2006,
Okay.
they had a heart failure self-management program. Patients got a 1-hour education session with a pharmacist or a health educator, and then they worked together to make a personalized diuretic dosing plan.
Right. Co-creation.
Exactly. And over 12 months, the patients in that self-management group, they showed a really strong trend towards fewer hospitalizations and deaths compared to the group getting standard care. And then there's another one, Praz and colleagues, a trial from 2005. This one directly compared patients using a flexible diuretic titration plan, they called it DT, against standard care.
Mm-hmm.
The DT group, they followed a daily 6-item checklist to guide their dose adjustments. And the results at 3 months were striking. A significant drop in ED visits, only 3% in the DT group versus 28% in the standard care group.
Wow, 3% versus 28%. That's a huge difference in just 3 months.
Huge, yeah,
Oh.
statistically very significant.
Okay, those results are fantastic. But it begs the question, if these plans work so well in studies, why aren't they just standard practice everywhere? What are the hurdles, the practical limitations stopping them from being rolled out more widely?
Yeah, that's a fair question. While the study show real promise, we do need to look at some of the limitations in how they were designed for wider use.
Okay.
Often the sliding scales they used were either highly individualized, which takes time and expertise, or they relied on these, well, somewhat clunky daily self-questionnaires.
Ah, so maybe resource intensive.
Exactly. That makes them harder and more costly to implement on a really large scale outside of a controlled research setting.
So it sounds like a big barrier is often just having the resources, the time, the staff to set these up properly and then support patients in actually sticking with them long term.
Yeah.
How do we bridge that gap between the promising study results and, real world clinics and EDs?
Well, that's where these newer, simplified, weight-based furosemide tools come into the picture. Researchers like NISNIC or COSAR have proposed these kinds of tools.
Niznik and Kosar.
Yes. They're designed specifically for outpatient titration. And the key is they're meant to be much easier for patients to understand and follow without needing constant hand-holding from clinicians.
Simpler, more practical.
That's the goal. However, there is a bit of a knowledge gap right now.
Oh.
Yeah, as far as we know, there haven't really been studies looking specifically at the effectiveness, safety, and just the practical feasibility of these simplified protocols in everyday clinical practice. That's kind of the next step we need to see.
Okay, but the recommendation from our source material is pretty clear. They strongly recommend these NISNIC or COSAR protocols. Why those specific ones? What makes them particularly suitable for, say, a busy, fast-paced place like an emergency department discharge process?
It really comes down to that balance of simplicity and effectiveness. They're designed to be easy to follow. They don't require a ton of extra resources to implement, but they're still comprehensive enough to provide good management.
Got it.
That combination, easy resource sparing, but still thorough, makes them potentially ideal for getting started even during that busy ED discharge moment.
Okay, so let's make this concrete. What does this actually look like for a patient? Can you walk us through a specific, simplified example of a CHF action plan using furosemide dosing, maybe adapted from what NISNIC or COSAR suggest?
Absolutely. Let's paint a picture. Imagine a patient, okay? Their dry weight, that's their ideal weight when their fluid is well managed. Let's say it's 80 kilograms.
Okay, 80 kilograms.
And their usual prescribed furosemide dose is 40 milligrams, taken orally once a day.
Got it.
So the core of the plan is daily monitoring. Step 1, weigh yourself. Same time every day, ideally morning after using the bathroom, before breakfast. Use the same scale. And critically, record that weight daily.
Consistency is key.
Absolutely. You need to track the trend. Now, the action part, let's say their weight goes up. If it increases to, say, 82 kilograms, that's 2 kilograms over their dry weight, the plan says. Take an extra 20 milligrams of furosemide for the next 2 days.
Okay, an extra dose for a couple of days.
Right, just a temporary boost to help shed that extra fluid before it becomes a bigger issue.
Yeah.
Now, the other way, what if their weight goes down? Say it drops to 78 kilograms, 2 kilograms below dry weight.
Right, don't want dehydration.
Exactly. So the plan says, reduce your usual furosemide dose by 20 milligrams for the next 2 days. If they normally take 40 milligrams, they'd take 20 milligrams for 2 days.
Okay, that makes sense. Prevents overdoing it.
Precisely. It avoids that overdiuresis and potential dehydration. And then the goal is always to get back to baseline. So you change back to your usual 40 milligram a dose once your weight returns to around that 80 kilogram mark and any symptoms like swelling have resolved.
Right.
And very importantly, there's a built-in safety net. A warning sign. If your weight keeps going up despite the extra doses, or keeps dropping despite cutting back, or if new symptoms pop up, that's the signal to see your doctor right away. Don't just keep adjusting on your own.
That safety instruction is crucial.
Yeah.
Okay, that seems very clear, very actionable. Now, is this kind of self-directed plan suitable for every CHF patient, or is there a specific group who benefits most? Are there, like, prerequisites?
Yeah, that's an important point. It's probably not for absolutely everyone. This approach tends to work best for patients who have, adequate health literacy. They can understand the instructions and the reasons behind them. They also need to be motivated to participate in their own self-care. It takes commitment to weigh yourself daily and follow the plan.
Right.
Also, crucially, they shouldn't have significant cognitive issues that would make it hard to follow the instructions correctly. And finally, it works best when it's part of ongoing care, meaning they still have close monitoring and regular follow-up appointments with their healthcare team for their overall CHF management. It's a tool, not a replacement for care.
That makes sense. It's about finding the right patient for the right tool. Okay, thinking bigger picture now. This has some really incredible implications for the healthcare system, doesn't it? You mentioned the ED is often the first stop for CHF flare-ups.
Yeah.
So if we could implement these patient-directed plans widely, starting right at ED discharge, that could really shift things, couldn't it? What's the potential broader impact.
Oh, potentially massive. It
Yes.
connects right back to that healthcare burden we talked about. If this approach helps more patients stay stable at home, it could dramatically reduce those preventable ED visits and those incredibly costly hospital readmissions.
Fewer revolving doors.
Exactly.
Okay.
And think beyond just one hospital or one region.
Mm.
This isn't just a Canadian issue. ED crowding is a huge problem in the US, in the UK, in many places.
Yeah.
So the potential utility of this kind of simple, patient-empowering approach could easily translate to those systems too. Imagine the ripple effect if this became a more standard part of care internationally.
Okay, let's bring it right back down to the individual level with that real-life success story you mentioned, the 72-year-old patient from the case study in the source article. Remind us what happened with him after they put this kind of plan into action.
Right. So this gentleman, after being treated for his acute CHF exacerbation in the ED, was ready for discharge. His plan included his standard oral furosemide, 40 milligrams daily, plus other important heart medications, what we call LV-enhancing meds, to help his heart pump better.
Okay.
But the key addition was the CHF action plan for managing his fluid volume going forward. They specifically used a protocol adapted from COSAR and colleagues, instructing him on how to adjust that furosemide dose based on his daily weight and symptoms. And the specific instructions for him were: increase your oral furosemide by 20 milligrams daily if your weight goes up by more than 1 kilogram in a single day, or by 2.5 kilograms over a week.
Got it.
And conversely, reduce the dose by 20 milligrams daily if your weight drops by more than 1 kilograms in a day, or 2.5 kilograms over a week.
So clear thresholds.
Very clear thresholds for action.
And the results. What did they find at his 5-month follow-up? You said they were impressive.
They really were. First off, symptom-wise, the patient reported no shortness of breath, no trouble breathing lying down, orthopnea, and no significant swelling, pitting edema.
Fantastic.
It actually used the action plan, self-adjusting his furosemide dose, on 4 separate occasions during those 5 months, successfully.
Wow, so he was actually doing it?
He was doing it, and his weight stayed stable, within a healthy range for him between about 78.4 kilograms and 83.8 kilograms. And crucially, he had 0 further hospitalizations for CHF flare-ups since starting the plan.
0 hospitalizations, that's huge.
Huge. And clinically, even his ejection fraction, that measure of heart pumping strength, had improved to 78%. But maybe the most telling thing:
What was that?
he told the clinicians he felt extremely motivated and engaged in managing his own heart failure using that action plan. It gave him a sense of control.
That's such a powerful outcome. Okay, so this deep dive has really highlighted the immense potential here, hasn't it?
Yeah.
A simplified, weight-based, patient-directed CHF action plan, something that can even be started right from the ED. It's really about putting effective tools directly into patients' hands.
Indeed.
Yeah.
It really feels like an underutilized tool, doesn't it? Something that could be incredibly helpful for clinicians in helping their CHF patients maintain that stable fluid balance euvolemia out in the community. And if they can do that, it follows that we could see a real reduction in those burdensome ED visits and hospital readmissions. It truly is about empowering patients, making them active, knowledgeable partners in their own healthcare journey. And it makes you think, doesn't it? This approach worked well in the studies for CHF. We saw the clear parallels with asthma. What other chronic conditions out there could really benefit from similar patient-directed, simplified action plans? Plans that give more control, more knowledge, directly to the individual living with the condition day in and day out. What really stands out to you thinking about this, about how this kind of self-management could genuinely transform health outcomes, not just for individuals, but maybe for our whole healthcare system?